So another way to decrease blood pressure is to interrupt the RAA mechanism. So you can do that with angiotensin converting enzyme inhibitors or ACE inhibitors like lisinopril, captopril, ramipril. And what they do is angiotensin, we've talked about it before, it's a powerful vasoconstrictor, and so it causes that not to be the case. So they don't make angiotensin 2. Angiotensin 2 also stimulates aldosterone and ADH, so inhibiting those causes vasodilation, or at least not vasoconstriction. With your ACE inhibitors, you also have the inhibition of the inactivation of bradykinin. And so you have more bradykinin, which is a vasodilator. Side effects include dizziness, headache, rashes. Angiotensin receptor blocking drugs, pretty similar to your ACE inhibitors, except they bind at your angiotensin 1 receptor, the receptor that's responsible for the vasoconstriction. They do not inactivate or inhibit the inactivation of bradykinin, and so you don't see that extra vasodilation. Losartan is an example of an ARB. Okay, enough about antihypertensives. Let's talk about anticoagulants. So it is really important that your body clot, right? If you get any sort of wound, it's important that you can close that wound. But sometimes clots can kill you, right? If it becomes too active or a clot gets stuck in a vessel that probably got too narrowed through like atherosclerosis or something, you can get a thromboembolism. Embolisms are particularly dangerous in the hearts, lungs, and brains, but you can also get them in the legs, which can cause pain. So let's talk about the coagulation pathway. So coagulation, or hemostasis, which is kind of the balance between the clot formation and dissolution, occurs when there is an injury. So the vessel is injured, there are intrinsic factors that are found on the vessel walls inside of the squamous cells. There are also extrinsic factors that activate, and here you can see the intrinsic pathway and the extrinsic pathway. They all kind of end with factor 10 to prothrombin, thrombin, to fibrin, and then your clot formation. It happens about in 4 stages. The first stage is thromboplastin is produced. So once the damage is done, like von Willebrand's factor and a lot of these other factors that we're not going to get into, activate, and then thromboplastin is activated, and then that converts prothrombin to thrombin, and then thrombin converts fibrinogen to fibrin, and it's that fibrinogen that makes, or that fibrin that makes these fibers that really holds the clot in place. And here you can see platelets in that fibrin in red blood cells in the fibrin, creating the patch. And then in the 4th stage, plasmin, which is converted from plasminogen, comes in and dissolves the clot. So thromboplastin, prothrombin to thrombin, thrombin goes fibrinogen to fibrin, and then plasmin dissolves it, which is made from plasminogen. So our anticoagulants, there's a bunch of different ones, but the whole mechanistic action is they inhibit clotting by inhibiting these clotting factors. They also inhibit platelet aggregation, so sticking together of these platelets, or the dissolving of clots. So heparin is probably one of the best well-known anticoagulants. Heparin is naturally produced in your body. We'll talk about this one a little bit more in detail in a bit. But what it does is it prevents thrombin formation, which then prevents fibrin, so on down the line. Warfarin is the next one. and it prevents several of your vitamin K dependent clotting factors like 7, 9, 10, and prothrombin. Your NOACs, your novel anticoagulants like Xarelto and Eliquis, they're going to be the newest ones, and they target factor 10A, and again stop prothrombin from making thrombin. And then antiplatelet drugs like aspirin, clopidogrel, ticlopamide inhibit the aggregation of your platelets. And then chelators like EDTA or oxalic acid, they bind calcium so coagulation gets interrupted. A lot of these are what you're going to see in test tubes for blood samples where they take it, they shake it to keep it from coagulating, right? So you can run tests on them. So here are your anticoagulant drugs, and here are the clotting factors that are affected, and we'll go through some of these in more detail, like the heparins. So these are naturally occurring mucopolysaccharides. Your body makes them. Also, cows and pigs make them. They were first identified in 1928. The heparins that are medically used are extracted from the lungs and intestines of cows and pigs, still to this day. There are two major classes, so you have like full weight heparins, and then there's a low molecular weight heparin. And use them a little bit different, and if you go to pharmacy school, you'll learn more about that. We're just not going to cover it here. The full weight heparins are able to do lipolysis on top of their anticoagulatory abilities, and so they're able to clear fatty molecules from the plasma because they stimulate this lipoprotein lipase. Indicated for a lot of different stuff: venous thrombosis, emboli associated with peripheral arteries, atrial fibrillations, postoperative deep vein thrombosis, pulmonary embolisms, transfusions, dialysis, so on, so on. Anytime you have something that you don't want to coagulate, heparins are a pretty safe choice for that. These can't be taken orally, though, so they all have to be parenteral. Side effects: hemorrhaging, right? It's anticoagulatory. It's going to cause bleeding. So you can hemorrhage, you can bleed into your mucous membranes called petechiae, those little red dots that you can see like in the skin. It can cause internal bleeding, fever, alopecia, which is hair loss, osteoporosis, thrombocytopenia, which is low platelet counts. If you give somebody too much heparin, or if somebody's bleeding out and you can't stop it, you can give protamine sulfate, and that's used in heparin toxicity. Warfarin was the only oral anticoagulant for 50 years. Coumadin. Even today, some people will refer to warfarin as Coumadin because it is the one, right? Kind of like old people when they talk about blue cheese, they might be like, I want some Roquefort, because that was the blue cheese dressing forever. Now we have some novel oral anticoagulants, or your NOACs. If somebody's on warfarin, they need to monitor their vitamin K ingestion. So warfarin is a vitamin K antagonist. It attaches to that enzyme and stops K from working in coagulation. If you eat foods that are high in vitamin K, it can cause warfarin to not work as fully as it should, and so you can get coagulations. If you don't eat enough foods that are high in vitamin K, then warfarin will work too good, and you start getting hemorrhaging. For your novel oral anticoagulants like Eliquis and Xarelto, there are no dietary concerns, but they all kind of have the same side effects: nausea, diarrhea, hypotension, urticaria. This is going to be hives, like these really itchy hives. You can have fatigue, alopecia again, hemorrhaging, especially in the gums and petechiae are going to be your most common. It's really cool. The discovery of warfarin, if you ever look it up, it was because there were these cows that were eating kind of this spoiled sweet clover, and the farmers noticed that those cows started having a hemorrhagic disease. They started bleeding out. And people who drank milk from those cows also started hemorrhaging, started bleeding out, because the warfarin molecule was also in the milk, which is crazy to think about. Then we have our antiplatelet drugs like aspirin. Aspirin irreversibly alters the platelets' cyclooxygenase enzyme. You remember way back when we talked about analgesics and aspirin and how that works. Clopidogrel or Plavix blocks ADP, adenosine diphosphate, and what it does is it stops the platelets from becoming sticky. Dipyridamole kind of works in that same fashion, except it increases adenosine, so as adenosine diphosphate, right, your ADP. But if you increase adenosine, it inhibits platelet reactivity, so it inhibits them from sticking together. It also inhibits phosphodiesterase within the platelets, so it's kind of like a two-sided attack. Antiplatelet drugs indicated for coronary artery disease, angioplasties, coronary stents, and that's just to prevent heart attack, stroke, and angina if these platelets start to coagulate, right, start to stick to each other. Side effects: headache, vomiting, rash, diarrhea. Cyclopidine can cause blood dyscariasis, and so that's just abnormalities like neutropenia, agranulocytosis, aplastic anemia, and thrombocytopenic purpura. This is what TTP looks like. Again, you see a whole bunch of petechiae, and there's not a lot of platelets cycling through the body. Lastly, we will talk about clot busters. These are your fibrinolytics and your thrombolytics, and they're used in the management of acute myocardial infarctions, ischemic strokes, and pulmonary embolisms. Streptokinase is kind of the go-to for this. We have some newer ones like alteplase, TNKase. Mechanism of actions is they convert plasminogen to plasmin, which then dissolves the clot. Side effects: hemorrhaging, because you're not being able to make clots, rash, nausea, headache, fever, musculoskeletal pain. These newer ones like Activase. Streptokinase works just as well as alteplase, but this one is super expensive because of the biotech that had to go into it, and so they sell this for a lot more when this one works just as well. And that's something you can look up whenever we talk about big pharma. That is it